Good evening. I am Dr. Kishore Kumar Povala, dermatologist from Godu. I am discussing about fungal infections, that is dermatophyte infections. Here, the fungal infections are caused by three genera of dermatophyte fungi, that is Trichophyton, Microsporum, Epidermophyton. Trichophyton, it attacks skin, hair and nail, and Microsporum, skin and hair, and Epidermophyton, skin and nails. Dermatophytes invade only into the stratum corneum, and the inflammation they cause in the result of metabolic products of the fungus and delayed hypersensitivity. Zoophilic fungi, that is transmitted to humans by animals, cause a more severe inflammation, and anthrophilic fungi is causes less inflammation. If we compare to anthrophilic, zoophilic is more inflammation. Here, presentation and course of the fungus. That is, the first number one is Tinea pedis. Tinea pedis is also called athlete's foot. This is most common type of fungal infection. The sharing of wash places, that is short showers and swimming pools, it predisposes to that infection. And most cases are caused by these three organisms, Trichophyton rubrum and Trichophyton mentagrophytes and Epidermophyton flaccosa. There are three common clinical patterns. Those are soggy interdigital scaling and a diffuse dry scaling of the source and recurrent episodes of vesication. Here, these three commonly presenting in the normal cases. And a tinea of the nails, that is toenail. Toenail infection is usually associated with Tinea pedis. The initial changes occur at free edge of the nail, which becomes yellow and crumbly, and sometimes with subungual hyperkeratosis. Usually, only few nails are infected, but rarely all. Fingernails lesions are similar but less common and are seldom seen without a chronic tinea rubrum. That is a chronic tinea rubrum infection of the skin of the same hand, becoming tinea hands. Tinea of the hands, that is Trichophyton rubrum is the main cause culprit, and a perceptible erythema of the one palm with a characteristic powdery scale in the cases. Tinea of the groins common, and it is a very common and affects men more often than women, sometimes unilateral or asymmetrical. The upper inner thigh is involved. Lesions expand slowly to form sharply demarcated and plaques with peripheral scaling. The scrotum usually spared here. The scrotum is won't affected. A few vesicles or pustules may be seen within the lesions. The organisms are the same as those causing tinea pedis, same organisms. Tinea of the trunk and limbs, characterized by flocks with scaling, erythema, most pronounced at the periphery. A few small vesicles and pustules may be seen within them. Lesions expand slowly and healing in the central leaves, a typical ring-like pattern. That is the common thing. Then tinea, coming to tinea of the scalp, Tinea capitis, that is called Tinea capitis. Usually a disease of children, and this fungi coming from human sources, that is anthropophilic, are caused bald and scaly areas with minimal inflammation and hairs broken off 3 to 4 millimeters from the scalp, and fungi coming from animal source, that is zoophilic fungus, that is called zoophilic fungus, induce a more intense inflammation and with boggy swelling. Pustulation and lymphadenopathy is a common, that is called chirine. The hair loss associated with may be permanent here. And favus, the next one is favus. This is one type of scalp fungus and caused by Trichophyton schonlini, is foul smelling yellowish crust surrounding many scalp hairs and sometimes leading to scarring alopecia. It is a permanent alopecia. And the scalp and hair of back children are especially prone to infection with the Trichophyton tonsurens. Next, coming to these complications of the fungus is fierce animal. The ringworm of the scalp can lead to a permanent scarring alopecia, and fluid fungal infections anywhere can induce vesication of the sides of the fingers and palms. That is called it reaction. epidemics of the ringworm occurs in schools. The usual appearance of fungal infection can be masked by mist incognito. Tinea incognito is mainly topical, commonly seen in the public. And here some differential diagnosis I am presenting. Scalp. If you take scalp, those infections are differentiated from fungus, that is alopecia areata, psoriasis, seborrheic eczema, carbuncle, and abscess, and trichotillomania. And in case of feet, we must differentiate from erythrasma, interdigital intratrigo, and eczema. Trunk, discoid eczema, psoriasis, candidiasis, pityriasis rosea. For coming to groin area, we must differentiate from candidiasis, erythrasma, and intratrigo, irritant, and allergic contact dermatitis, and psoriasis and neurodermatitis. Nails, psoriasis, paronychia, trauma, aging changes, and if coming to hand, chronic eczema, granulomanular, and xerosis, and dyshydrotic eczema. These are the main differential diagnosis of the fungus. Next, coming to investigations, mainly microscopic examination of the skin scraping, and nail clipping, plucked hairs, that is called. Cultures also one of the investigation. Wood slide is the main important investigation. Here the examination of the scalp usually reveals it is a green fluorescence of the hairs, which indicate Microsporum adoni and Microsporum canis infections. A technique used for screening children in institutions. The most common fungus causing tinea capitis is Trichophyton transferans. But this is not influence. And next, treatment. If coming to local treatment, this is need for minor skin infections and imidazole preparations, that is clotrimazole and meconazole, and magenta paint, that is old method, but so now also it is also in villages, it is a continuing they are doing. Occasionally dusting with the antifungal powders also useful. Topical nail preparations such as nail lacquer containing amyloriphen and cyclopyrax also we are using. Next, systemic. Systemic for mainly scalp fungus and nail fungus and widespread infection, fungal infection, tinea incognita. We are using that systemic antifungus. It is first number one is terbinafine. It is a fungicide. It cures chronic dermatophyte infections more quickly and more reliable. And for tinea capitis in children, a 4-week course of terbinafine is an effective, and a 8-week course of grazophilone is effective. Cure rates 70 to 90% can be expected for infected fingernails after a 6-week course of terbinafine, and for infected toenails after a 3-month course. It is not effective in Pitria versicolor or candidosis. And itraconazole. Itraconazole is now preferred antifungal drug, which occasionally damages the liver. So we have to find out any liver cases, very careful to give this itraconazole. And it is a reasonable alternative to terbinafine if this is if it's not contraindicated. It mainly, what is the function of itraconazole here? It interferes the cytochrome P450 system and interferes the metabolism of the other drugs. And it is effective in tinea corporis, cruris, pedis, and also in nail infections also it is very effective. And it is a fungistatic and also useful in pityriasis versicolor and candidiasis. Next, coming to grazophilone, it is largely reserved for the treatment of tinea capitis. It is a drug of choice in the tinea capitis. It is proved to be a safe drug, and treatment may have stopped because of persistent. It have some complications. Main complications are headache, nausea, vomiting, and skin eruption. So it should not be given in pregnancy or to patients with alveolaria. And candidiasis. It is a caused by Candida albicans, is a classic pathogen, and its predisposing factors are obesity, moisture, and immobility, diabetes, pregnancy, the use of broad spectrum antibiotics, and the use of contraceptive pills. It is a more. Next, the presentation of fungus. Oral candidiasis, one or more whitish adherent plaques like bread sauce, and appears on the mucous membranes. If wiped off, they leave an ariasis. And angular stomatitis, usually in denture wearers, may be candidal. And candidal intertricho, a moist glazed area of erythema, and maceration appears in the body folds, and the edge shows soggy scaling and outlying and sac-like papulopustules. These changes are most common under the breast and in the armpits and groins, but can also occur between the fingers of those whose hands are often in water. Next, coming to main genital side. Genital candidiasis most commonly present as a sore, itchy vulvovaginitis with white curdy plaques and adherent to the inflamed mucous membranes and a white discharge. The eruption may extend to the groin folds, and diabetes, pregnancy and antibiotic therapy are common predisposing factors. And if coming to paronychia, it is acute paronychia, usually bacterial, but is a chronic paronychia. It is a candida, maybe the sole pathogen, and it is found with other opportunities such as Proteus and Pseudomonas. Predisposing factors including wet work and poor peripheral circulation and vulvar candidias. And coming to treatment part, predisposing factors should be solved and eliminated, and infected skin fold should be separated and kept dry. And those with chronic paronychia should keep their hands warm and dry. And amphotericin and nystatin and imidazole groups are all are effective and topically. And for the mouth, these are available as a oral suspensions and lozenges and oral gels. For other areas, Candida use creams, ointments, pessaries, and in chronic paronychia, the nail folds can be packed with an imidazole cream and drenched in imidazole solution and several times a day. And genital candidiasis responds well to single dose treatment with either itraconazole and fluconazole. These are the main fungal infections I covered. Thank you for giving this opportunity.